The impact of birth settings on pregnancy outcomes in the United States. In the United States, births in hospitals happen 98.3% of the time. Home births occur 1.1% of the time, and freestanding birth centers, 0.5%. During the first year of the COVID-19 pandemic, from 2019 to 2020, hospital births decreased from 98.33% to 98.01%, with resulting birthing increases in home births, 1.03% to 1.26%, and freestanding birth centers, 0.53% to 0.61%. Providers by birth setting. At hospitals, doctors and doctors of osteopathy, DOs, account for 90.2% of births, and certified nurse-midwives, 9.1%. At freestanding birth centers, certified nurse-midwives count for 54.9%, and other midwives account for 36.8%. With home births, other midwives assist 50.6% of the time, certified nurse-midwives, 29.6%, and others account for 19.2%. While the absence of high-risk factors may deem a pregnant patient low risk, there is never zero risk. Although birth is usually an uneventful occurrence requiring little intervention, it can be interrupted by a pathological or emergent event with little warning, which would require the activation and cooperation of many individuals from different professions, with little time to spare to prevent the pregnant patient and/or the soon-to-be-born child from being negatively affected. A major obstacle when comparing outcomes is that dangerous situations that began out of the hospital, in homes and/or birth centers, and are then transferred to a hospital setting for intervention, results in faulty data compilation, with the ultimate results, adverse or otherwise, attributed to the receiving hospital rather than the intended out-of-hospital birth location. The United States has among the highest rates of maternal and neonatal mortality and morbidity of any high-resource country, particularly among Black and Native American patients. There are no significant studies that compare maternal mortality or severe morbidity between planned home births, birth center births, and hospital births. Currently, the data compiled in the United States is insufficient and unable to describe and understand level of maternity mortality and severe morbidity between places of birth. Out-of-hospital births are associated with fewer interventions, and the avoidance of unnecessary procedures and interventions is an important reason cited by pregnant patients desiring an out-of-hospital birth. The premise that an out-of-hospital birth setting implies safety permeates the support and promotion of planned out-of-hospital births. But the view that the paucity of interventions creates safety has been proven wrong over time. There's a need for obstetric services to review their routines of standard interventions and move more towards a quantum improvement in patient-centered birth. Long-held standard processes and routines can be reasonably liberalized, including routine maternal placement in beds, IV placements, electronic fetal monitoring, oral intake, artificial rupture of fetal membranes, vaginal examinations at will by various examiners, and strict timelines for delivery. The CDC vital statistics natality data are publicly available and are collected from birth certificates which provide multiple data points on each of the over 3.5 million births in the United States. These data have the benefits of being population-based without selection bias and provide a complete count of births by important characteristics, such as birth settings. No other country has a comparable data set with this level or volume of information. The Midwives Alliance of North America's MANA's Division of Research, called the MANA Statistics Project, MANA Stats, and the American Association of Birth Centers, AABC, called the Perinatal Data Registry, PDR, formerly called the Uniform Data Set or UDS, have collected and reported on data from out-of-hospital births using birth registries. These registry-based studies are voluntary data collections showing births at home or in birthing centers, collecting less than 50% of births, and unlike vital statistics, they're not population-based, limiting their generalizability. Planned out-of-hospital births in the U.S. are associated with increased perinatal morbidity and mortality, with studies showing consistently higher neonatal morbidity and mortality when compared to hospital births. The more than double neonatal mortality rate and the increased neonatal morbidity rates compared to planned in-hospital births, with an absolute increase of approximately 1 to 2 deaths per 1,000 births for out-of-hospital birth, has recently been acknowledged by those favoring out-of-hospital births in the U.S., after initially criticizing the same findings for using incorrect data. In this slide, we show neonatal mortality between hospital and out-of-hospital births by different risk factors. Neonatal mortality for hospital births is significantly higher for all risks when compared to out-of-hospital birth. The reality is that the fetuses and newborns' health and lives can be saved by delivering in the hospital, where many interventions can be life-saving and are unavailable at out-of-hospital births, such as risk-reducing inductions, timely treatment of serious infections, timely prevention of cerebral palsy, treatment of obstetrical hypertension, availability of ultrasonography, and improved management of emergencies such as abruptio placentae, uterine rupture, umbilical cord prolapse, or shoulder dystocia. In other high-income countries with established midwifery systems, for example Canada, the Netherlands, England, Germany, New Zealand, and Australia, midwives have uniform national training and licensing requirements and guidelines. Both hospital and home birth midwives are well integrated into their country's healthcare system. Midwives have strict guidelines to appropriately select low-risk patients for home births, and in the event a transfer from home to a hospital is required, the transition is often well coordinated. In the U.S., home birth midwives do not have these guidelines. The United States is unique among all high-income countries providing midwifery services. There are 3 separate midwifery credentials: Certified Nurse-Midwives, CNMs, Certified Midwives, CMs, and other midwives, often known as Certified Professional Midwives, CPMs, with differing levels of education and training. CPMs lack the level of professionalism that CNMs and CMs have, and CPMs have lesser standards of education, including many trained through only apprenticeship roles. Most importantly, U.S. home birth midwives refuse to risk out patients for home births. Instead of discouraging home birth, should physicians and out-of-hospital midwives work together to make birth in all settings safer? While good communications are essential for all birth settings, it requires professional collaboration, consultation, and establishing relationships, even more so for those participating in planned home births. Attending a planned home birth, especially when there are high-risk factors, regardless of one's training or experience, is not acting in a professional capacity, because this results in clinically unnecessary and therefore clinically unacceptable perinatal risk. It's not consistent with the ethical concept of a profession for any attendant to plan a home birth in a high-risk pregnant patient and represent themselves as a professional. The lack of a uniform standard of accredited formal education for CPMs, who perform most out-of-hospital births in the U.S., remains a critical missing component. The U.S. should not accept a lesser standard for those midwives, CPMs, who perform home births when compared to the high standards of CNMs and CMs, who mostly perform hospital births and receive hospital privileges through standard processes. Because out-of-hospital midwives work independently with reduced access to consultation with other healthcare professionals, their standards should be transparent, equitable, and meet maximum societal expectations. Many planned U.S. home births have a high prevalence of risk factors. Criteria for selection of appropriate candidates for planned out-of-hospital births include the absence of pre-existing maternal disease, absence of significant disease and complications with onset in pregnancy, singleton pregnancy, cephalic presentation, gestational age greater than 36 weeks and less than 41 weeks, no prior uterine surgery, absence of advanced maternal age, and nulliparity. Several factors are critical to reducing perinatal mortality rates and achieving favorable outcomes in out-of-hospital births, including the appropriate selection of candidates for out-of-hospital births, the availability of a certified nurse-midwife, a certified midwife, or a midwife whose education and licensure meet International Confederation of Midwives global standards for midwifery education, providers practicing obstetrics within an integrated and regulated health system, ready access and availability of board-certified obstetricians to provide consultation for qualified midwives, including use of telehealth, standardized guidelines, when to transport a patient to the hospital, and improved access to safe and timely transport to nearby hospitals. All obstetrical care providers have the professional obligation to be clinically competent and to make the protection and promotion of the patient's health-related interest one's primary concern. When the pregnant patient is deciding between planned hospital and planned out-of-hospital birth, a professional should ask, what obligations do they have in counseling patients about the inherent risks of out-of-hospital births, in-hospital births, personal risk assessment, and where do the safest resources exist for labor and delivery? The ethical principles of beneficence, non-malfeasance, respect for autonomy, and social justice are often misinterpreted and misunderstood, and rarely personalized when it comes to patients' decisions to have an out-of-hospital birth. The principle of autonomy respects the inherent right of a person with capacity to make an informed decision. Patients have a right to express their preference and operationalize their preference of the location of their birth setting. However, respect for autonomy does not require a professional to automatically implement a patient's preference simply on the basis that the patient has freely expressed it. Support for out-of-hospital births, with its increase in perinatal morbidity and mortality, the safety of the pregnant patient and soon-to-be-born fetal patient's interest is not served. An important component of respect for a patient's autonomy is presentation of unbiased, evidence-based information. Informed consent is essential to enhance patient autonomy. Patients who are interested in an out-of-hospital birth, in order to prevent maternal mortality from a cesarean delivery, should be informed that contrary to information that cesarean deliveries are linked to maternal mortality, studies have shown that cesarean deliveries are rarely a cause of maternal death. Informing patients inquiring about planned home births includes decreased intervention rates, known increased perinatal risks, different types of midwives attending home births, and the unavailability of options regarded by many as essential for safe childbirth, including access to competent neonatal care, the option of neuroaxial anesthesia, emergency cesarean delivery, IV medications such as antibiotics, and induction of labor when medically indicated. It is an immutable truth that when compared to hospital births, there are increased, avoidable, adverse perinatal outcomes in out-of-hospital births in the U.S., both for those with risk factors and for those without. Professional, patient-centered care requires that planned hospital births should be supported for all pregnant patients and should be strongly supported for high-risk patients. The impact of birth settings on pregnancy outcomes in the United States.